I'm going to present in English. I would like to thank all the guys from abroad who traveled all these miles to attend this course. I hope the cadaveric part is worth it. And I hope you have learned some Greek with all these Greek talks. Otherwise not, I will present in English in this instance. By the end of this talk, you should be able to identify arthroscopically there we are, excellent. By the end of this talk, you should be able to identify arthroscopically the ATFL and the syndesmosis. These are the two aims of our talk. So we're going to talk about the anatomy, evaluation of stability arthroscopically, the ATFL and the syndesmosis, arthroscopic anatomy, the 7 points as you saw in Alex's presentation. What is important is when you have a normal ankle arthroscopy, you should not be able to actually see the anterior aspect of the lateral malleolus. It is covered by the ATFL and the inferior syndesmosis. If you see it, then it does mean that you have an instability. So the other important knowledge we see is an old knowledge, but it's a new knowledge, is this part of the syndesmosis, that is the inferior anterior talofibrillar ligament, and this is this structure here. And this is normal anatomy. You need to remember this. This is normal anatomy and actually is in continuation with the ATFL, with the anterior talofibrillar ligament. They form an arc. Why is this important? Because that's the classical paper from Nikolopoulos back in 2004. They considered this as a cause of impingement. It is not a cause of impingement. You should check this intraoperatively and don't dissect this, don't debride it if not necessary. This has been shown in this beautiful cadaveric study because when you are in dorsiflexion, it does not touch the cartilage. When it goes to plantar flexion, it does touch this denuded area because that's where it's taught. So again, it is a part of the normal anatomy. Instability, you all know about instability. We perform this test, the anterior drawer test, whichever test you want. The problem with the clinical testing is, can we identify which areas are really injured? Can we really anatomically identify the area of the instability? And the answer is we cannot. This is a review we published last year in clinical foot ankle clinics. You cannot differentiate a high ankle sprain from a lateral ligament tear just by clinical examination. This does not mean that the clinical examination is not useful. It is useful. It's just not helping us decide when and how to operate. 75% of the injuries can be detected, but not the rest of the 25%. And these are probably the best clinical tests. When we cannot have a specific diagnosis with a clinical test, we should have additional imaging and arthroscopy or arthroscopy. And the additional imaging, of course, are the x-rays that you are all familiar with. The CTs, there are a dozen of methods described, and we're still debating which one is the best. And the MRI, there is an abundance of MRIs in Greece. Who reads the MRIs? What is the accuracy of the MRIs as they're being performed? Are they being performed with a boot, with a coil or not? So these are all issues. And the negative is that the MRI cannot identify the abnormal movement. They cannot identify actual dynamic movement. So ultrasound covers this aspect, and we have a better ultrasounds now. The problem is that they're operator dependent, but this is an arthroscopic course. We're going to talk about arthroscopic anatomy. That's why you're here. So this is a normal looking ATFL. So this is the ATFL as it runs down, and it should cover the lateral compartment. And you should not be able to slide your 4.0 millimeter scope easily in the lateral compartment. And again, if you have the lateral bortle and you insert your probe, you will see that there is a resistance. That's the oblique basset ligament, which is intact. You feel the tension of the ATFL at the back of your probe. And if you're trying to push in the anterior syndesmosis, you have a resistance. You cannot do even if you apply force. And of course, you cannot easily slide your probe in the lateral gather. This is the normal looking. Let's go to the abnormal. Now, you appreciate all this space. All this space suggests that there is an element of lateral. That's the lateral ATFL here. Usually it is scarred and you find it in the bottom, and this is the proximal remnant of the ATFL in this case. And again, if you see this case, you see the denuding of the lateral malleolus, all this exposed bone. This is where the insertion of the ATFL used to be. So this is a case of a lateral ankle instability. And how easily can we slide the probe without causing any trauma in the lateral gather, which is not the case in the instability, in the stability. So if we pull, that's another case, if we pull the scar tissue, again, we identify the denuded area of the anterior lateral malleolus, which is here. And this is the scar tissue that the body tries to form. Where is the ATFL? We'll find it somewhere there in the bottom. We'll find some fibers that are white, nice, shiny looking, and that's the transition zone. This is the normal ATFL, that's the scar tissue. This is where we should reattach it if we perform, as Alex showed, an arthrobrostrom. That's an unusual case that I'm going to show because we have a fresh injury. This is a professional athlete with a concomitant syndesmosis injury. That's why we did the arthroscopy. And here we will catch, this is a detached distal, that's the distal stump of the ATFL, and the insertion of the ATFL, the origin is intact. And this patient had also a syndesmotic injury. So this is how we're trying to do the arthrobrostrom. That's the basset ligament, that's the Nicolopoulos ligament, that's the inferior syndesmosis, which is intact in this instance. You see the crispine cartilage, it does not cause impingement. And we're trying to identify the scar tissue, the remnant of the ATFL at the bottom of the ankle joint, and catch it. And if you do, even with this mosquito clamp or whichever instrument you have, you'll see that you can actually pull the whole ankle if you pull that. And this is a very strong ligament. By doing that, you are sure that this is where you need to place your sutures with whichever device you are familiar with, whichever company you work with. And then you again test the stability of your sutures here. And by denuding further on the anterior cartilage of the lateral malleolus, you can insert some type of anchor, and by doing that, you test the strength of your sutures. And finally, you reinsert the ATFL, basic steps of an ATFL arthroscopic rostrum, which is going to be performed tomorrow. And finally, moving on to the syndesmosis. This is how the syndesmosis looks like when it's ruptured. You see this is the tibia, and there is the fibula. And not only can we slide the probe, we can actually twist the probe. We can twist the probe inside the ruptured syndesmosis. Syndesmosis is a complex, it's not a ligament. Usually we're talking about 2 of the 3 elements of the syndesmosis that have been ruptured. The one and only classification I'm going to show in my presentation, grade 1, 2, and 3. Easy to remember. Grade 1, from the first, you don't have a true diastasis, just a sprain. In grade 3, you see the diastasis in the x-rays. The problem is the grade 2. What do we do with those? These are potentially unstable or dynamic unstable, and these are the ones that can cause problems. What do we do? Do we operate or do we go conservatively? And if they're unstable, we need to operate. How will we decide upon that? Again, with imaging, how would it look like in arthroscopy? These are the usual open book ones. This is a posterior open book here, and this is an anterior open book in the CT and MRI with quite normal looking x-rays, both of them. But this is how it would look like. Now that you have the image from the syndesmosis, you know that this is a scope. This is a burr that can enter the syndesmosis, and by entering the syndesmosis easily, you know that this is a failed open book, a syndesmosis that needs repair. And again, those landmarks, we are now looking at the posterior. This is the tibia, the fibula, and the talus. And again, if we see the probe twisting, and there is a little bit of, in the fresh injuries, a little bit of bleeding from the syndesmosis, this is an unstable syndesmosis that needs also some type of stabilization. One remark though, we're talking about twisting the probe. Which probe? Your probe, my probe. How big the probe should be so that we have a true instability. You need to be aware of that. it should be more than 3 millimeters in most cases. So you need to be aware of how big your probe is. So you slide it and you have a diagnosis. And that's another very useful arthroscopic test, the drive-through test. So if the interosseous ligament is intact, we cannot slide our probe. In order for us to slide our probe, we need to have a ruptured interosseous. So we have this drive-through sign, and actually the probe can dance around and just go proximally. This shows that we have a rupture of the syndesmosis that needs stabilization. And again, this is an acute injury. You appreciate the bleeding. We can also do a hook test or a drawer test, any type of test, external rotation test, intraoperatively with the arthroscope and confirm that, or just slide the probe. A chronic injury, even with all this scar tissue, where the syndesmosis appears intact, if you slide your probe, you will see that this is just scar tissue. It's not a normal ligament, so we do have instability, and we need to do a fixation. You can do screws, you can do this device, whichever you want. And at the end, you can also appreciate the accuracy of your reduction, an issue always with the syndesmosis. You can check it arthroscopically, and that the hook cannot enter the syndesmosis. So you need to be aware of the arthroscopic anatomy. This presence of the oblique ligament is constant, and it's not a pathology in most times. And you'd be able to identify the ATFL and the syndesmosis. Thank you.